Okay, today's lecture is thyroid disorder. So thyroid disorder, as usual, pituitary disorder, the one I explained in pituitary disorder, hypothalamus produce thyrotropin releasing hormone, TRH. TRH act on anterior pituitary thyroid gland in anterior pituitary and then secrete TSH. TSH act on the thyroid and produce thyroid hormone, T3, T4. Okay, so there is negative feedback mechanism. It means that when there is high T3 thyroid hormone, then it negative feedback on anterior pituitary and then negative feedback on hypothalamus. So the one hypothalamus. So the one the primary, you need to understand is primary and secondary, and then thyrotoxicosis, hyper and hypo. So primary is the one I also explained last week. Thyroid cause is primary cause. Anterior or pathology in anterior pituitary or hypothalamus is secondary cause. Okay, so the thyroid disorder pathology is in thyroid, then it leads to reduced thyroid hormone production or increased thyroid hormone production. This is primary cause. Okay, if the anterior pituitary pathology is in the anterior pituitary and then the hypothalamus, then it cause secondary. It is a secondary cause. Okay. Cannot go to, yeah. Okay. Okay. So yeah, the primary cause is okay. The thyroid cause is primary cause, and then the thyroid pathology is in thyroid. It is primary cause. If pathology is in the anterior pituitary or hypothalamus, then it is secondary cause. So so there is excess thyroid hormone production, hyperfunction, excess thyroid hormone production. It is called hyperthyroidism. Thyroid hormone, decreased thyroid hormone production, it means that thyroid hormone deficiency, it is called hypothyroidism. So hyperthyroidism, increased thyroid hormone. Thyroid gland is hyperfunction. So thyroid gland is hyperactive and it produces increased thyroid hormone. This is hyperfunctioning of the hyperthyroidism. Thyrotoxicosis is any cause that increase T3, T4 level. It leads to thyrotoxicosis. Okay, I explain in here. So thyrotoxicosis here, so hyperthyroidism. Hyperthyroidism means thyroid gland is hyperactive. It means that the grave disease. Grave disease is diffuse hyperplasia of the thyroid gland. Thyroid gland is hyperplasia. Diffuse hyperplasia means the whole thyroid gland hyperplasia, increase in number. Hyperfunctioning of multinodular goiter. It means that the one after this, I will show you goiter. Goiter means enlargement of the thyroid gland. And one of the nodule, I will show you nodule later. Nodule means like a mass. One of the nodule is hyperactive. It called toxis multinodular goiter. It means that one of the nodule is hyperactive. And then thyroid adenoma. It's also same. The adenoma, even it is benign tumor, it produces increased thyroid hormone, hyperfunction. It is called leads to hyperthyroidism. Okay, and then iodine-induced hyperthyroidism. This one easy. Neonatal thyrotoxicosis associated with maternal grave disease means mother has grave disease. So the one the baby has, this one, it leads to increased thyroid hormone level in the neonate. So this is called neonatal thyroiditis because mother has increased thyroid hormone level. This thyroid hormone cross the placenta and reach the baby neonate, and neonate has, the newborn has has increased thyroid hormone level. Okay, do you notice here? The one the baby has thyrotoxicosis high T3 T4 level. Okay, and then secondary is here. Secondary is because of pituitary cause. Pituitary functioning adenoma. TSH secreting pituitary adenoma means functioning. Last week we discussed about functioning adenoma and non-functioning adenoma of the pituitary. Functioning adenoma means the gland produce more hormone. So in thyrotoxico secondary hyperthyroidism, this thyrotrope gland, adenoma in thyrotrope gland, and this adenoma produce more thyroid hormone, more TSH hormone, then it causes hyperthyroidism. So this is secondary. So more TSH hormone act on the thyroid gland, then thyroid gland produce more thyroid hormone. That's why it is called hyperthyroidism. So hyperthyroidism means the gland itself is hyperactive. Okay. Okay, another is not associated with hyperthyroidism. Not associated with hyperthyroidism means, okay, when the thyroid gland is, one is the one easy to say is factitious thyrotoxicosis. You take thyroxine drug. So in the blood, there is high T3, high thyroid hormone level. It is not, this exogenous means it is not produced from the gland. It produced, you take from the outside, you take it, right? So exogenous. But even you take it, because of in the blood, there is high thyroid hormone level. So when there is increased thyroid hormone level, it leads to thyrotoxicosis. Any condition that increase thyroid hormone level, it is called thyrotoxicosis. So increased thyroid hormone level may be due to this thyroid gland hyperactive of the thyroid, hyperfunction of the thyroid gland itself, or may be due to other exogenous cause. Another is struma ovary. Struma ovary means ovary. You know that ovary produce estrogen. In struma ovary the ovary produce thyroid hormone, ectopic thyroid hormone, the one you study in the paraneoplastic syndrome. Okay, even the benign tumor, but it produce thyroid hormone. Tumor in benign tumor, the ovary, but it supposedly it must produce estrogen, but it produce thyroid hormone. It is called, it leads to thyrotoxicosis. Okay, this increased thyroid hormone level is not because of hyperactive of thyroid gland. This increased hormone level is because ovary produce high increased thyroid hormone. Okay, these two. So here, this granulomatous thyroiditis, subacute lymphocytic thyroiditis. Do you notice itis? Itis means inflammation. So when there is inflammation, tissue destruction. Tissue destruction means the one that thyroiditis means inflammation of the thyroid gland. So thyroid gland, there are glands. So when there is inflammation in the thyroid gland, then this gland, they rupture. When they rupture, then the thyroid hormone in the colon release into the circulation. Then it leads to increased thyroid hormone level. It causes thyrotoxicosis. So the thyroid gland is not active because of thyroid gland destruction. Inflammation, severe inflammation leads to inflammation cause thyroid gland destruction. When thyroid gland destruction, it releases thyroid hormone into the circulation. So it releases thyroid hormone into the circulation. So in the blood, there is increased thyroid hormone level. Then it is called thyrotoxicosis. But in this year, hyperthyroidism is thyroid gland itself is hyperactive. It means that thyroid gland itself, it is hyperactive and produce increased thyroid hormone. This is hyperthyroidism. Any condition that increase thyroid hormone level in the blood, it is called thyrotoxicosis. Like Cushing syndrome, any condition that increase corticosteroid level in the blood, it is called Cushing syndrome. Thyrotoxicosis say any condition that increase thyroid hormone level in the blood, it is called thyrotoxicosis. So in here, the hyperthyroidism is hyperfunction of the thyroid gland. Not associated hyperthyroidism may be due to exogenous cause, exogenous in marker, or the ectopic or ovary produce thyroid hormone. In here, thyroiditis is when there is severe inflammation, then the thyroid follicle destruction because of inflammation. So the hormone, thyroid hormone in the colloid release into the circulation, so that increase thyroid hormone level. Okay, faham no? Because this one you need to understand. And no response, huh?
Understand, doctor.
Okay. Please reply, or otherwise we're talking with the screen like gila. Just reply. Okay. Clinical cause of hyperthyroidism. So the one increased hyperthyroidism, one is thyroid hormone, it increased basal metabolic rate. So it increased tissue oxygen consumption. So increased tissue oxygen consumption and then increased ATP production. So here you see increased BMR, heat production, oxygen consumption, heat production. So the one for heat loss, there is vasodilation, peripheral vasodilation. So peripheral vasodilation present with sweaty, soft and warm flesh skin because of vasodilation. Why vasodilation? To increase heat production because of for heat loss. Okay. In the body, there is increased BMR, increased heat production. So to prevent for heat loss, there is peripheral vasodilation. So this person, hyperthyroid person, important is their heat intolerance because they produce heat. So they cannot stand heat intolerance. Okay, another is there is vasodilation. Vasodilation reduce peripheral resistance. So in the blood pressure, total peripheral resistance determine the diastolic blood pressure. That's why this hyperthyroidism, when there is vasodilation, cause decreased peripheral resistance that lead to reduced diastolic blood pressure. Okay, so increased BMR, one is heat intolerance because of increased heat production, cause of vasodilation. And then this vasodilation also affect decrease peripheral resistance. So decreased peripheral resistance leads to decreased diastolic blood pressure. Okay, and then increased BMR means increased catabolism breakdown. So when there is increased tissue breakdown, their patient present with weight loss, but they have increased appetite but weight loss. They eat makan but weight loss. Okay, so these are because the reason is because of increased BMR, basal metabolic rate. Okay, CVS, cardiovascular system, this thyroid hormone increase the sensitivity and number of B-cell receptor. So this increased B-cell receptor, there is increased chronotrophic effect, inotrophic effect. And then because of increased another reason is increased tissue oxygen consumption. One is B-cell receptor and sensitivity increase. Another is second reason is increased oxygen consumption. Therefore, there is increased heart rate, increased stroke volume. So increased heart rate, patient present with tachycardia. Sign is tachycardia, palpitation is a symptom. Okay, so increased workload, it leads to cardiomegaly. Tachycardia, increased heart rate. So there is patient has increased workload. So increased workload lead to cardiomegaly, enlarged. So it can lead to heart failure. Okay, and then the stroke volume, especially in cardiac failure, heart failure, especially in old people. And then patient who has pre-existing heart disease, they have high risk to get heart failure. And then tachycardia. Tachycardia leads to arrhythmia. Therefore, arrhythmia, congestive heart failure are seen in old people who have pre-existing heart disease. Okay, who have underlying heart disease, they have high risk to get arrhythmia and heart failure. Okay, inotrophic, so increased stroke volume. Because of increased tissue oxygen consumption, there is increased stroke volume, increased cardiac output. So cardiac output determines the systolic blood pressure. So there is increased systolic blood pressure. So there is a wide pass pressure. Okay, and then the thyroid hormone increase sympathetic leads to sympathetic overactivity. So it causes sympathetic overactivity. So the sympathetic overactivity symptoms: tremor, hyperactivity, emotional lability, anxiety, inability to concentrate, and insomnia. Okay, the one like you see the restless feature. When you have stress, there is sympathetic overactivity, right? Sympathetic overactivity means increased catecholamine production. So this catecholamine, you have tremor, hyperactive, emotional lability. Okay, so this and then another is the thyroid hormone act on the GI tract, so it increase GI motility. So the patient present with hypermotility leads to diarrhea, and then because of diarrhea, patient present with malabsorption. Thyroid myopathy. So thyroid hormone is low dose is involved in protein synthesis. High dose cause muscle protein breakdown, right? So the thyroid hyperthyroidism, there is protein breakdown. So protein breakdown leads to proximal muscle weakness and muscle mass. Okay, so another is thyroid hormone, excess thyroid hormone. There is the potassium loss, electrolyte imbalance. So this electrolyte imbalance also leads to muscle weakness. Okay, bone. In the excess thyroid hormone stimulate osteoclast activating factor, so stimulate bone resorption. So this bone resorption, this is chronic hyperthyroidism. It got present with osteoporosis because of bone resorption for long duration. So this osteoporosis can cause fracture. Okay, and then the hyperthyroidism, they are more or less plus or minus associated with thyroid gland enlargement. Okay, there is sympathetic overstimulation of the superior tarsal muscle to raise up. So the function of superior tarsal muscle is upper eyelid, raise the upper eyelid. So sympathetic overstimulation, the eye is wide, staring gaze, and lid leg. So you see here the superior tarsal muscle activate sympathetic overactivation. So this superior tarsal muscle sympathetic overactivation, you see here, you can see the eyeball. Okay, proptosis means this is okay, this is eye, and then proptosis means like this. This is eyeball. Here there is a clear space. Okay, here down clear space. This is proptosis. Okay, normally a normal person eye is like this, right? The whole the eye is filled with eyeball. But proptosis means there is a clear space, cornea, can see the cornea up and below. So this is proptosis. Lid retraction is superior tarsal muscle retraction here. So because of sympathetic overactivity. So even the eye you see here, normally when you see the lower object, the object at the lower part, then this eyeball become closed, right? This upper eyelid become closed. So when the one that normally we see the object, it become lower, then the eye follow this object, right? So the upper eyelid looks closed. But in here, sympathetic overactivity, this superior tarsal muscle contraction stimulation, it leads to lid retraction. Okay, and then lid retraction, lid lag. So the one that after some time this cornea cannot close properly, then it can cause a cornea ulcer. But it's the one that there is a can cause complication. Normally, the one that present with white staring gaze and lid leg. Okay, this is lid leg, lid retraction. Then can see the eyeball. So the hyperthyroidism, thyroid act on increased hyperthyroidism, increased basal metabolic rate, activate CBS, CNS, GI, okay, and then muscle. So myopathy is proximal muscle weakness is because of protein breakdown and electrolyte imbalance. In reduced muscle mass is because of protein breakdown. Where is proximal muscle? Is it in upper limb? Is it here? Where is the proximal muscle? Is it in the muscle at the humerus or muscle in the fibula, radius ulnar? Muscle at the radius ulnar or muscle at the humerus? Proximal muscle.
Humerus.
Yeah, proximal means close to the central body. So proximal muscle means close to the one in humerus, muscle at the thigh. These are the proximal muscle weakness. So the one muscle in humerus. So the patient they complain is when they comb their hair, then they say the muscle, the pain in the muscle weakness in the proximal muscle in the upper limb muscle, this humerus deltoid, this muscle, they feel proximal muscle weakness because especially when they comb their hair. Okay, and then lower limb proximal muscle weakness, they complain during squatting position. They want some toilets they are squatting position, right? So when they go to toilet and difficult to get up, this is proximal because of muscle weakness. So the one the patient they complain that the one they have difficulty in comb their hair and when they sit cannot get up. This is due to thyroid myopathy. Okay, bone resorption is seen in chronic, not in acute type. Okay. Grave disease. So grave disease is autoimmune disease. As autoimmune disease, it is as usual common in reproductive female, and autoimmune disease they are associated with other autoimmune diseases like pernicious anemia, SLE, type 1 diabetes mellitus. Okay, so in grave disease, antibody is TSH receptor. So the antibody to TSH receptor. So normally the TSH act on the TSH receptor and stimulate and then release thyroid hormone. Okay, but in grave disease, antibody to a TSH receptor. So this antibody always stimulate the TSH receptor. So this thyroid epithelial cell synthesize thyroid hormone all the time. So the one in the blood, there is increased thyroid hormone level. Normally in normal physiological process, TSH act on the TSH receptor and stimulate thyroid hormone synthesis. When there is increased thyroid hormone, then there is a negative feedback. So it act on the anterior pituitary, so no thyroid hormone, less TSH production. This is in normal physiological process. But in grave disease, this antibody mimic TSH. So this antibody is like similar like clone. So antibody act on the TSH receptor and stimulate thyroid hormone production. So the one even in the blood there is increased thyroid hormone. There is negative feedback, but negative feedback is it only reduces TSH secretion, but the antibody cannot block the antibody. So antibody still act on the TSH receptor and increase thyroid hormone production. Okay. So clinical feature of grave disease, what do you notice? Her eye. You see here, exophthalmos, protrusion of the eyeball, proptosis, protrusion of the eyeball. So the one in here, after some time, this cornea can get injury. The one I told you just now, the one that protruded of the tongue, protruded of the eye. So the one the cornea can get injury. Okay, so the proptosis, exophthalmos, and then this exophthalmos, the cornea, can cause conjunctival irritation and corneal injury. It is due to infiltrative ophthalmopathy. It means that behind the eyeball there is a extracellular matrix connective tissue accumulation. Okay, because of this antibody, thyroid antibody, and then grave disease patient, they have sign and symptom of hyperthyroidism that we discussed just now. And then here, do you notice thyroid gland enlargement? And then the important is ophthalmopathy and dermopathy. So the clinical features of grave disease is sign and symptom of hyperthyroidism, thyroid gland enlargement, ophthalmopathy, and dermopathy. So dermopathy is also known as here pretibial mixed edema because of extracellular matrix accumulation. So in grave disease, the thyroid gland is enlarged, the fuse symmetric enlarged, and then like a beef. It's like a beef. The consistency is like a beef. So these are the thyroid follicles. So thyroid follicles, do you notice here? Here. So thyroid follicle lining epithelials, they are active, so they are tall columnar cell. And then you see here the clear space. This clear space is because we call scallop margin, because the cells reabsorb the colloid in the center of the follicle. The active cell reabsorb the colloid, so it presents with scallop margin. Okay, because of increased thyroid hormone production. Thyrotoxicosis, thyroid storm. So thyrotoxicosis, thyroid storm is a medical emergency. It's acute onset of severe hyperthyroidism. So, okay. So this is the acute onset. Okay. So cause is thyroid hormone, excess thyroid hormone, it increase sympathetic overactivity. So sympathetic means increased catecholamine release. So in thyrotoxicosis, thyrotoxic crisis or thyroid storm, the cause is there is increased catecholamine level, because excess hyperthyroid, certainly there is increase of thyroid hormone. So this thyroid hormone stimulates sympathetic overactivity. So it's the one stimulate catecholamine release. Okay, so catecholamine, the adrenal catecholamine adrenal medulla, right? Arrhythmia, tachycardia, arrhythmia. Okay, tachycardia, arrhythmia, and then it is common in grave disease. So what are the precipitating factors? Patient has underlying disease. Precipitating factor is infection, surgery, stop taking of antithyroid drugs, and sudden stress. They can cause thyrotoxic crisis. Okay, so thyrotoxic crisis, the cause is because of increased catecholamine level. Hepatic hyperthyroidism. Hepatic hyperthyroidism means thyrotoxicosis occur in old age, and they have underlying other diseases. So because of these underlying diseases, comorbidity mean like patient has underlying respiratory disease, heart disease. So these diseases blunt the features of excess thyroid hormone. So patient, but the one that normally they present with unexplained weight loss or the heart failure, then we notice that this patient has thyrotoxicosis, hyperthyroidism. Okay, so normally these patients, their clinical features are not obvious because their clinical features are hidden by the other diseases. Diagnosis of hyperthyroidism. So this one easy lah. Hyperthyroidism means T3, T4 level increase. Okay, T3 toxicosis, T3 level increase. And then in here the one need to explain is primary and secondary. Primary is primary increased thyroid hormone, then there is negative feedback on anterior pituitary. Therefore, serum TSH level, anterior pituitary thyroid stimulating hormone level is reduced in primary hyperthyroidism because of negative feedback. Okay, this one understood. The one that in secondary is due to anterior pituitary cause or hypothalamus cause. So anterior pituitary, there is excess TSH production, so there is increased TSH level. Primary is thyroid cause, so there is negative feedback, so reduce TSH level. So TRH, stimulation test is when give TRH, then TSH level is increased. This is thyroid releasing hormone stimulation test. In Graves' disease, antibody to TSH receptor is positive. And then thyrotoxicosis, hyperactive. The one how to measure the radioactive iodine uptake by the thyroid gland. So like Graves' disease, it diffusely increase uptake of radioactive iodine, the whole gland. Toxic adenoma is here. These are the toxic area. These are the hyperactive area. Toxic multinodular goiter. Toxic adenoma, the one in here, this area is hyperactive area. Thyroiditis, normally it is inflammation, not because of gland is not hyperactive. Because of inflammation, there is really inflammation leads to follicle destruction. So this follicle, the one in the thyroid hormone in the follicle release into the circulation. So in the circulation, thyroid hormone level is high, not because of hyperfunction of the thyroid gland. This toxic adenoma, toxic multinodular goiter, Graves' disease, gland is hyperactive. Okay. So that's why radioiodine uptake is increased in these glands. Hypothyroidism. So hypothyroidism is inborn area of the one, I think you understand these causes, okay? Iodine deficiency, Hashimoto, I will explain. Iatrogenic cause, drug cause. So primary is the thyroid gland itself. The secondary is hypothalamus or pituitary cause. Okay, this cretinism. Cretinism is seen in the infant. Myxedema is seen, hypothyroidism seen in adult. The one you remember, gigantism and acromegaly. So acromegaly is the one that growth hormone deficient, excess growth hormone. So excess growth hormone before epiphyseal closure, that is, it is occur in children. It present with gigantism. The one excess growth hormone occur after epiphyseal closure, that is in adult, then present with acromegaly. Okay, here also same cretinism and myxedema. Hypothyroidism occur in children, it is called cretinism. Hypothyroidism occur in adult, it is called myxedema. Okay, Hashimoto thyroiditis. So just now, Graves' disease, autoantibody is TSH receptor. In Hashimoto thyroiditis is also autoimmune disease. So autoimmune disease common in middle-aged women. In autoimmune disease, the antibody is thyroglobulin and thyroid peroxidase. So the one just recall immunology lecture. So thyroid antibody to thyroglobulin, antibody to thyroid peroxidase. So the one this antigen antibody complex is distracted by antibody dependent cell mediated toxicity. Okay, and then the one the antigen antibody complex, it attract the inflammatory cells. So thyroid gland, thyrocyte injury, cell injury. So clinical feature of cretinism. So thyroid gland is important for brain. Thyroid hormone is important for brain development. So the one depend on the cretinism means thyroid hormone deficiency in children. So before thyroid gland development, the one the iodine thyroid hormone deficiency before thyroid gland thyroid hormone deficiency before thyroid gland development, then present with severe mental retardation. Okay, maternal TS normally this cretinism is involved brain involvement, right? So the one that normally mother T3 T4 from mother cross the placenta to the fetus for brain development. So the one that this cretinism depend on the mental retardation is depend on the thyroid hormone deficiency. So the one here thyroid gland development, it means that baby thyroid gland cannot synthesize own thyroid hormone. Thyroid hormone deficiency in mother before thyroid gland development, then present with mental retardation. So the thyroid hormone deficiency in mother, after thyroid gland development, after fetal thyroid gland development, then there is no effect on brain development. So this one is the important. Okay. So maternal thyroid hormone deficiency effect on the baby fetus thyroid gland development. So mother thyroid hormone deficiency, mother has thyroid hormone deficiency before baby has thyroid gland and development, then present with mental retardation. But when after this mother has thyroid hormone deficiency, after the baby already has thyroid gland development, then it doesn't affect on the brain development of the baby. Okay. So the cretinism main is the thyroid hormone deficiency. It affects on brain, it affects on the skeletal muscle, bone growth. So they present with here short stature. And then coarsening of the feature, wrinkle and tries very large protruded tongue. And then enlarged visceral organ and abdominal muscle. So you see here protruded belly and then umbilical hernia. These are the clinical features of cretinism. Clinical feature of mixed edema. Mixed edema means thyroid hormone deficiency in adult. So the one that present with just opposite the hyperthyroidism. Insidious onset of slow physical and mental activity, fatigue, apathy, mental sluggish, slow speech and intellectual function, expressionless face, okay, coarsening feature. Okay, the one important is here the non-pitting edema, reduced BMR. So reduced BMR, so the one that reduce blood flow, so sweating, less sweating, and patient skin is cold, pale, and pale skin. Okay, cold intolerance, cold and pale skin. So because of decreased BMR. Cardiac low oxygen tissue consumption and then decreased sensitivity to beta receptor, so there is reduced cardiac output. So reduced cardiac output leads to dyspnea, decreased exercise capacity. Okay, and then the thyroid hormone increased LDL receptor. So hypothyroidism, there is less LDL receptor, so it leads to more LDL and more total cholesterol. So increased cholesterol, that leads to increased risk of atherosclerosis. And then GI motility. GI motility also becomes slow, so present with constipation. Anemia. So anemia, the hypothyroidism, patient present with anemia, normally they present with macrocytic anemia because the fat accumulate in the fat deposit in the RBC. And then the hypothyroidism, hyperthyroidism, they are plus or minus thyroid gland enlargement. Mixed edema coma is seen in it is caused by hypothyroidism. Thyroid crisis is hyperthyroidism. Mixed edema coma is seen in hypothyroidism. So the one the patient is loss of conscious, reduced conscious level, conversion, and body temperature is also reduced. Okay. It is medical emergency because mortality rate is 50%. Okay, diagnosis of hypothyroidism, measure the TSH level as usual. Primary, there is no primary hypothyroidism. There is no negative feedback, so increase TSH level. Secondary is anterior pituitary or hypothalamus cause. So there is no increase of thyroid TSH level in secondary hypothyroidism. Okay, and then hypothyroidism, T3, T4 level reduced, and there is a reduced LDL receptor, therefore increased LDL and increased cholesterol. And then Hashimoto, there is autoantibody to thyroglobulin and thyroid peroxidase. I think this one easy to understand. Okay. Goiter means thyroid gland enlargement. So the causes of goiter are iodine deficiency or goitrogen or enzyme defect. So this it leads to decreased thyroid hormone synthesis. So when there is reduced thyroid hormone level in the blood, it stimulates pituitary to release TSH. So TSH act on the a thyroid gland, and then thyroid gland become hypertrophy and hyperplasia. So this hypertrophy and hyperplasia leads to thyroid gland enlargement. So this is the thyroid gland. So there is a thyroid gland enlargement. So here, these are the gland, nodule, the one, the gland, they become hyperplasia, increase in the glands increase in number. Okay, and then compress the adjacent normal cell. The glands all are increase in number, then compress the adjacent normal cell. Okay, quite that here, thyroid gland enlargement. Multinodular quatermy here, nodule, many nodule. Diffuse quatermy, the whole thyroid gland enlargement. Just now, the one I mentioned that toxicity, toxis multinodular quater, it means that one of the nodule is toxis, one of the nodule is hyperfunction, then we call toxis quater. Okay, multinodular toxis quater. Okay, what do you notice? Here, one is cosmetic effect lah, clinical feature. Thyroid gland enlargement. So one is cosmetic effect. Another is the important is this pressure effect. This thyroid gland compress the trachea. So patient present with airway obstruction. Below trachea, then press the esophagus. So patient present with dysphagia, difficulty in swallowing. Or it compress the large vessel in the neck and upper thorax, then present with superior vena cava syndrome. Okay, so this multinodular quater, it may be euthyroid, normal stage, hypothyroid, or hyperthyroid. The risk of cancer is less than 5%. When they have, then they present with multinodular follicular carcinoma. Neoplasia thyroid here, follicular carcinoma. So iodine deficiency, multinodular quater can progress to follicular carcinoma, but less than 5%. And then this follicular carcinoma, they spread by blood. Okay, so the one thyroid neoplasm, it is a single nodule. It is common in young men. Young female, autoimmune disease common in middle-aged female. The thyroid cancer is tumor is common in young male. History of radiation. Benign is follicular, malignant is adenoma, malignant is carcinoma. And then other types are papillary. Papillary is associated with radiation exposure. So the one they spread with lymphatic. Here follicular is spread with blood. So lymphatic means the one the patient, sometimes there is no thyroid gland enlargement, but only present with cervical gland enlargement. Okay. Medullary carcinoma is cancer arise from the parafollicular seizure. So parafollicular seizure, they produce calcitonin. So this calcitonin can cause amyloidosis. This one you can differentiate hyperthyroid, hypothyroid, hypothyroid sleeping. So any question? Any question? Please ask.
Doctor.
Yeah.
Can you please explain the scallop margin?
Or scallop margin. Okay, do you know, you see here, this one, the margin is less. Okay, here, the margin you see here, clear space here, like a tooth, like a kiki. You see kiki. This is scallop margin. So scallop margin means when there is scallop margin, it means that thyroid follicle is active. It can synthesis the thyroid hormone. Okay, it resolves the discolloid and then synthesis the thyroid hormone. So this scallop margin, the one in follicle, when we see the scallop margin, we can say that this thyroid gland. And then the gland, normally the one lining epithelium. If this columnar epithelium, then the gland is active. Flat epithelium, then the lining flat, then we can say it is inactive gland. So in Graves' disease, the whole gland is hyperactive. So the whole gland, all the follicular cells, they synthesize thyroid hormone. So the thyroid hormone, they use this colloid from they use this colloid for thyroid hormone synthesis. So in the colloid, there is a active scallop margin in here. Okay. This is goal
Alright,
line.
doctor. Thank you.
Okay. Other 10 minutes left. Any question? Please ask. Any question, sister, brother?
I think so far no.
Oh, cosmetic effect. Is it? Shakira. Cosmetic effect mean not gentle lah. You know, like there is a mask, so not beautiful. I mean, like, oh, people see there is a mask, so not beautiful. Cosmetic effect. Not the cosmetic is not like eyeshadow, not this one. The one you see here, the people who have quieter, they shy. They don't want to show because they think this is abnormality. And then not beautiful, they think. So they don't want to show. This is called cosmetic effect. Okay. Other? Yeah, Shakira, okay, faham? Okay. Okay, and question, please ask.
Doctor,
Yeah.
can you explain about the serum TSH level, about the diagnosis?
Sorry, which one?
Serum TSH level at the diagnosis.
The hypo or hyper? Okay, TSH level. Just I explain hyperthyroid first lah. So hyperthyroid, the one that okay before TSH level, you see here this one. So there is a hypothalamus act on the anterior pituitary. Anterior pituitary release TSH. This TSH act on the thyroid receptor, TSH receptor on the thyroid gland. Then this TSH receptor stimulate thyroid hormone to produce thyroid gland to produce thyroid hormone. So when there is increased thyroid hormone level, the one in here, when there is increased thyroid hormone level, there is negative feedback to anterior pituitary and the hypothalamus. So just now the hyperthyroidism. Hyperthyroidism means there is increased thyroid hormone level in the blood. So when there is increased thyroid hormone level, it has negative effect or negative feedback on anterior pituitary. Therefore, anterior pituitary TSH level is low. This is in primary hyperthyroidism. Pathology is at a thyroid. Okay, but if pathology is anterior pituitary, it means that there is secondary hyperthyroidism. Then the pathology secondary hyperthyroidism pathology is there is increased TSH production. So even there is high thyroid hormone level, there is no negative feedback because anterior pituitary has pathology. It produces TSH, so it doesn't affect on. So the thyroid hormone, there is no negative feedback effect on the anterior pituitary. Okay, so primary hyperthyroidism, thyroid hormone is pathology, therefore there is increased thyroid hormone level. And then there is negative feedback on anterior pituitary, therefore anterior pituitary level is low. Secondary hyperthyroidism pathology is at the anterior pituitary. Anterior pituitary produce thyroid hormone, the TSH. So the one that it cannot control by negative feedback. So therefore TSH level is high and also thyroid hormone level is high. Okay, same as hypothyroidism. Hypothyroidism, thyroid hormone level is low. So if pathology is in the thyroid gland, so there is no negative feedback, right? So TSH level is high because there is no negative feedback. If pathology is in the anterior pituitary, it means that the anterior pituitary cannot produce TSH hormone, then TSH hormone level is low. Faham?
thank you.
Okay. Any question? Please ask. Input dequervain and subacute colloids of thyroid pus. Yes, dequervain thyroiditis, subacute lymphocytic thyroiditis. When there is inflammation, first inflammation causes tissue destruction. So this lymphoid follicle destruction. So when there is lymphoid follicle, not lymphoid, this colloid follicle, this thyroid gland follicle destruction. So in the thyroid follicle, there is a colloid. So thyroid hormone is stored in the colloid, right? So this thyroid hormone released into the circulation. So in the circulation, because of destruction in the circulation, first thyroid hormone level is high. This is called, it leads to thyrotoxicosis. Not thyroid gland is not active because of thyroid gland destruction. Okay. Any question? Please ask. Any question, sister, brother? Increased catabolism due to reduced diastolic blood pressure. No, catabolism is because of increased BMR. Increased basal metabolic rate mean increased breakdown, right? Increased basal metabolism mean increased BMR. Increased basal metabolic rate mean increased tissue breakdown. So there is increased tissue breakdown. That it leads to decrease. It leads to decreased protein mass. Decrease. It leads to weight loss. Okay. Increased BMR, basal metabolic rate. Okay, here. Yeah. The one that increased basal metabolic rate. Then there is this increased basal metabolic rate leads to increased catabolism. This catabolism tissue breakdown leads to weight loss. Okay, there are causes. One is increased basal metabolic rate. This increased basal metabolic rate leads to increased catabolism. Another is this increased basal metabolic rate cause heat production. So this heat production cause vasodilation. Vasodilation leads to reduced diastolic blood pressure and heat intolerance. Okay, so the one first is this. The primary cause is increased basal metabolic rate. So the one basal metabolic rate cause increased catabolism and increased heat production. About factitious thyrotoxicosis is okay. The patient is the one we suspect. This patient is hypothyroid. Then we give thyroid hormone, the one that anti-thyroid hormone. So the one it is called factitious thyrotoxicosis. Exogenous, like Cushing syndrome. Cushing syndrome, the one we give corticosteroid, with the patient take corticosteroid. This is exogenous corticosteroid. So exogenous corticosteroid increase corticosteroid level in the blood. Increase corticosteroid level in the blood. It leads to Cushing syndrome. Factitious thyrotoxicosis means the one we take thyroid hormone. Okay, the orally, the one as Uber. So the one this thyroid hormone, this thyroid hormone increased thyroid hormone, this Uber increased thyroid hormone level in the blood. So it leads to thyrotoxicosis. Factitious means the one we take as a medicine. Shadia, okay? Nah, Shadia. Okay. The one, the question I answer all, Tikwabe. Any question? Please ask. Any questions, sister, brother? Why brothers are so quiet these days? Brother shy. No question. Oh, no need to ask. Faham. It's okay. You read first. If you don't understand, you can ask me anytime. Okay?
Okay.
Okay. Any question? If no question, then I stop the lecture. Today lecture. Is there any question, sister, brother?
So far,
Why so quiet? Huh?
I think so far no question, Doctor.
Okay lah then. Okay, then I stop the lecture. Thank you.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Welcome.